Okay, so good morning, everyone. Uh, Appreciate your getting up early this morning. Enjoyed Dr. Burke's talk. I promise not to read every slide too. This is a talk about early cardioendocrine risk after spinal cord injury. For many years, we've talked about late risk, but we have some new data that suggests this occurs earlier than we had planned, and forces us to contemplate the complexity of reversing it once the risk factors have developed and they're more difficult to treat. So at the very least, using the term low-hanging fruit, I want to define it as easier, less expensive, and more effective. And we can find something better than we have with respect to lifestyle intervention. I think that it needs to be pursued. Oops. Okay, in the 2018 World Report on Disabilities, 1 in 7 people on this planet have a disability. Prevalence is increasing. It's noted that aging and chronic disease, and also injuries of people who are older, such as the older population of individuals with spinal cord injury who are now falling at age 60 and older, and then developing incomplete spinal cord injuries. It's a relatively new population. 1 in 5 people with a disability have, at least by the World Report, considerable difficulties in functioning. And in the first paragraph of the entire report, they start with diabetes and all-cause cardiovascular disease as being among the most concerning things for the disabled population that we're going to face in years to come. Now, if you're not familiar with cardiometabolic syndrome, and I've given any number of talks on it, it is a cluster of risk factors sustained by a high percentage of the population. It is prothrombotic, it's certainly pro-inflammatory, but by most definitions, there are 5 risk factors. Not all the definitions are harmonized. The most widely used are the American Heart Association and the National Heart, Lung, Blood Institute, which indicate 5 risk factors: abdominal obesity, abdominal obesity, fasting triglycerides above 150 and certainly above 200, low levels of the cardioprotective high-density lipoprotein cholesterol in men, below 40, in women because of estrogens below 50, hypertension, which is continuing to be adjusted for lower levels of criteria that define it, and insulin resistance or impaired fasting glucose. The American Heart Association uses fasting glucose of 110 milligram percent. World Health Organization pretty close at 100 and just a little bit more conservative. And we've written a number of papers on this that define it, assess how you identify it. It's actually not terribly difficult. When I go to my physician twice a year for my exams, all of this information is obtained in about 5 minutes. So, certainly it takes a body mass. There's a fasting blood, which gives you 3 of these and a blood pressure. So it wouldn't seem to be an onerous task to measure it, especially in a population that it is at risk for it and seldom seems to be tracked for it. If we look at the data in the literature about what percentage of the population sustains these things, about a third of people with spinal cord injury, by our reports and others also, satisfy the criteria for a frank cardiometabolic syndrome. And that syndrome gives them a risk for future cardiovascular disease that's the equivalent of an individual who already has existing heart disease, even if they don't have existing heart disease, or a frank diagnosis of diabetes, even though they might not have type 2 diabetes. So it confers the same level of risk, and that's the concern for the clustering of these risk factors. Overweight obesity, our latest report was 81% of the population by population-specific criteria is either overweight or obese, and obviously that covers a high percentage of patients for one of the 2 major risk factors, the other actually being impaired fasting glucose. Elevated triglycerides in about 20% of the population, but don't feel comfortable about this quite yet. I'll explain why you shouldn't feel comfortable. The most common of dyslipidemias going back into the 1980s has been an identified low level of high-density lipoprotein cholesterol, probably due to physical deconditioning. We reported that in something like 1986. Our data from 2007 are the same. Our data from 2016 published are the same. So this pretty much seems unchanging. Hypertension in 30 to 60% of the population. One of the questions that appeared and disappeared, but is whether autonomic dysreflexia contributes to hypertension. Is this a hypertension stimulus? And in individuals with low blood pressures, because they have cervical spinal cord injuries, injuries above the level of sympathetic outflow at T1, does 90/60 become the new normotension? Okay, and do levels above that, where we might see 120, okay, or 110 systolic, is that in fact their new hypertension? And we don't know the answer to that question yet, but it's been estimated, at least by Andrei Kusakov, that individuals with cervical spinal cord injuries undergo about 20 bouts a day of some level of mass reflex. Okay? And the effect on vascular cell wall, the effect on interactions with other risk factors isn't known yet, but which is why this isn't the most widely represented of the risk profiles. And insulin resistance, Duckworth reported the first cases of elevated diabetes after spinal cord injury in 1980. Any number of papers, including ours, Dr. Gator has joined our center as chair of the Department of PM&R. He's written extensively about this. We've written together and have now published together on it. So probably at least 50% higher than the prevalence of insulin resistance and diabetes in the non-disabled population, and maybe even a little bit higher. In 2007, we published with Armando Mendez in the Department of Medicine, looking at guideline-based assessments of insulin resistance in the population, and we reported 34%. We repeated that study in 2016, and it was 36%, and that's pretty much where the population is holding. So there is high risk, and we're starting to understand what the risk factors are, which of course drives the questions about how we can best intervene on it. In the past year and a half or so, we have published the first guideline for identification and management of cardiometabolic risk. This practice guideline was commissioned by the Consortium on Spinal Cord Medicine, which is 27 organizations representing all professional fields that deal with spinal cord injury. I chaired that. Dr. Gator was on it, and actually a very important member of the panel. And we've now issued recommendations for surveillance and follow-up of cardiometabolic risk. And one of the exciting things for me now that Dr. Gator is here is that we actually get to put this into action and see if we can more effectively manage this as patients even go through rehab and then come out, and usually, at least our expectation is that they will gain considerable body mass somewhere between 2 and 7 months post-injury. So there are no guidelines on it. At the very least, and to be fair and balanced, the guideline has generated a lot of discussion, and not the least of which is some controversy. Populations are small for spinal cord injury. We don't have the luxury, as most of the non-disabled guidelines, of having thousands or tens of thousands or multiple tens of thousands of patients that form the evidence base for it. Additionally, we don't have a lot of follow-up on hard cardiac events, and by hard cardiac events, I'm specifically myocardial infarction, stroke, and sudden death as the result of cardiovascular disease. So there are some who think this was premature, and even used the term unsubstantiated. It's generated some interesting point-counterpoint discussions at conferences. Dr. Gator was on the panel. Sunil Sabharwal from Harvard was on the panel. But at the very least, even Dr. Stillman was compelled to suggest that, you know, this is an important first step toward understanding and treating a number of secondary cardiometabolic effects of spinal cord injury, which they recognize exist. And to do nothing is to do nothing, and that's one of the reasons the consortium felt it was important enough to go forward with this. And I've suggested that, as happens with cardiovascular guidelines, there will be another one in 5 years. There will be more evidence, and at the very least, we've identified areas of weakness or limitation in the evidence base that are needed to firm up that guideline and make it a little bit more spinal cord injury specific. So we have now something that we've never had before, which is a specific recommendation. And actually, a large part of the recommendation had to do with omitting certain pharmaceuticals from the pharmacopoeia of spinal cord injury, in large part because they can conflict with other medicines. And in things like orlistat, one doesn't want to mess with a drug that's going to change neurogenic bowel. So we've had no arguments about that whatsoever. So you know, one of the questions, you know, we've always assumed that there's this 2 to 7 month window post-discharge in which people develop this syndrome. You know, they are sedentary, perhaps for the first time, perhaps not in their lives. We've never really considered that this was in large part a pre-morbid issue, but we're starting to think that way as well. We have obviously a Neidler model system directed by Dr. Liz Felix in the Department of PM&R. And one of the sub-grants on this was a modular grant that we developed between the 5 centers listed on the right. We are the lead center: Spalding in Boston, TJ and McGee in Philly, Ohio State in Ohio, and Rancho outside LA. And we started picking up individuals with spinal cord injury. This number is now up to 100. We were actually rolling along nicely until about 2 months ago, when we pretty much hit a brick wall and are not picking up people as they go through rehab now for obvious reasons. But we pretty much secured everyone less than 2 months. So, and we've used the guidelines to assess you know, which of the risk factors they have. We've taken medications to see if they were being treated for any of them. 32% of the about 100 people now who have come through these rehab centers qualify for a frank diagnosis of cardiometabolic disease by guideline. And not a single one of them has been treated for any of their specific risks, be it obesity, dyslipidemia, or diabetes insulin resistance. Almost 80% were overweight by population-specific criteria. And even if you don't use population-specific criteria, if you use the criteria that are used for overweight and obesity of the non-disabled population, this number is still about 40 to 45%. So a lot of people we haven't considered are coming into spinal cord injury overweight, okay? And that, you know, really need an almost immediate intervention if that isn't to become, you know, the body habitus for the rest of their lifespan. When we use homeostasis model assessments, 57% were insulin resistant. That's higher than we've seen before. Almost 60% were dyslipidemic, you know, predominantly from HDL, but, you know, in some of the older subjects, we're seeing climbing triglycerides, certainly above 150, and in some cases above 200. Now, this study was actually an outgrowth of a work that was done by Denise Tate up at Michigan a number of years ago, in which she asked individuals with spinal cord injury what they knew about their risks. Okay? And it was a study we did not participate in because we didn't like some of the questions that were being asked. We thought they were too complex. You know, one of the questions was, have you ever been told by a healthcare professional that you have dyslipidemia? And in talking to Denise, when when the study was being designed, I said, do you really think people with spinal cord injury know what dyslipidemia is? In fact, you would get different opinions from healthcare professionals about what dyslipidemia is, but what are you looking for? So we didn't do that. We didn't participate in that study. It's been published, even though we think it's a little bit flawed. But we revised the questions, put them through a peer support group to make sure they were understandable, and then again revisited at the time of discharge, and we're also following up at year 1 and year 2 post-discharge, what people knew about their risks. And what I can say is that of all of these risks that were seen, only about 3 of them were known by the subject with spinal cord injury. One subject asserted she was diabetic, but we measured, obviously we did objective clinical measurement on all these subjects. She wasn't even close. Another claimed she was hypertensive, but neither of the reports were accurate. And when we looked at a regression model on this to see, whether we could identify the predictors for cardiometabolic disease, the 2 strongest predictors were age and neurological level of injury. And this was closely followed, and not quite statistically significant yet, but close, was inflammatory stress as assessed by pro-atherogenic inflammatory cytokines. So inflammation comes into this process. We often think of atherogenesis as a bland lipid storage disorder, when in fact it's a dynamic process that involves pro-atherogenic inflammatory overexpression and secretion of cytokines, and how they are actually probably higher in the spinal cord injured population than the non-disabled population. And we'll come back to that in a little while. Now, I had suggested not to feel comfortable about the 20% prevalence of hypertriglyceridemia in the population. And this was a study we did in 2005. We were the first to look at postprandial lipemia. So rather than fasting levels, what happens to triglycerides as they are ingested and then processed for metabolism and energy use. And part of I guess my incentive to do this was a comment I got from a physician colleague. Dr. Green hired me in 1984, and shortly thereafter, we were looking at electrical stimulation of the lower extremity. We did the first studies in electrically stimulated cycling, and one of the things we were trying to do was to increase muscle mass. And I had a colleague who's a well-known physician scientist who said, of muscle mass, it looks pretty, but what does it do? And I always thought that's an important question, because certainly muscle is a sink for blood-borne triglycerides. It metabolizes them and it removes them from what will eventually be their atherogenic domain. So we took a number of healthy individuals with paraplegia and a non-paraplegic control group matched for gender, age, and pretty much for body mass index. And we took the fasting blood from them and then fed them a milkshake composed of Haagen-Dazs, brownies, and cookie dough ice cream, and heavy whipping cream. We mixed that up in a slurry and we made a milkshake out of it. I can tell you I had a lot of volunteers for this study, and most of them enjoyed it a lot. And what we found was a divergence in the processing of triglycerides in individuals with paraplegia. It was slow. Now, there are 2 things you should note on this slide. The first is the fasting triglyceride levels, which were almost identical in the 2 groups. Okay? And if any of our patients went to see Dr. Gator and he looked at a fasting triglyceride of 100, he would probably be very happy, because that's a really good fasting triglyceride. Except the hypertriglyceridemia is only revealed in the postprandial state. And the other thing is that these bloods were taken at 4 hours. So we started at 0800. We took the bloods at 4 hours, this would be the point at which individuals would probably feed again. Okay? And this was one feeding over 6 hours only, because we wanted to look a little bit at the rate of decay. But if they were to consume another meal, and if that meal had a composition that is typical for the spinal cord injured population, which is about 43% of calorie intake from fat, okay, well above recommended levels, this triglyceride level would go even higher, and then at dinner time, who knows where it would be. And the risk is that this leaves triglycerides in circulation. Those triglycerides are oxidized to triglyceride-rich lipoproteins, and that's what invests across the endothelial wall, is consumed by macrophages that become foam cells, and the foam cells are the atheroma. So trying to process triglycerides is a very important part of risk management in this population. We did this study in 2005. Racine Emmons up at Bill Bauman's lab in New York at the Bronx VA, and Mount Sinai repeated it in 2010 and got exactly the same thing we did. We changed the diet because this really isn't a meal, this is kind of a fat load. We changed this in 2015 to a representative nutrition of the population, which at 43% fat, we fed individuals a quarter pounder with cheese, a large fry, and a bottle of Trutol. Okay? And Trutol being 75 grams of glucose in an orange soda. And this is essentially the reference meal for spinal cord injury, because it is 43% of calories from fat, and we've computed that out, and both the macro and micronutrient composition of that meal are pretty close to what we see in the population. So one of the things we're interested in, and it's an in-progress work by David McMillan, who's a PhD student in our laboratory, is the influence of exercise conditioning on the processing of micro and macronutrients using isotope tracer studies, excuse me. We expect to have some of that information in the next couple months when his dissertation is written. This is a concern, it's a silent concern, and others have been starting to look at the postprandial period instead of just what's happening in the fasting state. So we have sarcopenic obesity, in deference to Dr. Gator. He refers to it as neurogenic obesity. There are subtle differences between those two, but I think we agree. We both agree, and he's written a lot with Dr. Gary Farkas, who is coming here for his postdoctoral fellowship, or maybe here by now. I think it's next week. There is imprudent nutrition, high caloric intake relative to daily need. We first published that in 1992. It's not any different in 2020. Sedentary lifestyle, when Kim Anderson and Rachel Cowan were here, we published 3 papers looking at barriers to lifestyle intervention, barriers to healthy eating, barriers to exercise participation. Those papers are in the literature now and are well cited. There's this pro-inflammatory risk. If one eats a pat of butter, it sets off an inflammatory risk. So nutrition, high-fat diet has an impact on inflammation. Once there's accelerated vascular disease, musculoskeletal injuries, we always think of the neurogenic bladder, whether someone has a clinically diagnosed UTI or not. There's probably subclinical bacteriuria. Pain is proatherogenic, so are fractures, pressure injuries. And so there's a lot of inflammation going on in the body of an individual with spinal cord injury. And these are cytokines that are not distinguished by the liver or other organs as being of any particular origin. They're just pro-inflammatory. So, and we'll show you what happens if we start to control them. And obviously, there's a risk of sympathectomy, of adrenergic dysfunction for injuries above T1 and above T6. for functional adrenalectomy, and we know that those have impacts on risk. We, certainly we cited the neurological level of injury has it, and we continue to try to understand what's different about someone with an injury above T1, and then in that interval between T1 and T6, and then T6 and further on down to lower levels in terms of risk. So what happens if we aggressively treat this proatherogenic inflammatory stress early after spinal cord injury? And this was a study, and I give credit to Dr. Greg Bigford, who does almost all of the preclinical studies on this, and we'll get to myostatin inhibition in a few slides. We wanted to look at what would happen if early in spinal cord injury, in a preclinical model, we gave an anti-inflammatory drug. And most of the anti-inflammatories that are used clinically are cyclooxygenase inhibitors, but there's a very, very old NSAID called disulcid, which is salsylate, which is an NF-kappa B inhibitor. It was first cited in the British Journal of Medicine in 1902. And has actually been considered a potential alternative to metformin in its ability to lower blood glucose in individuals who have prediabetes and diabetes. So what we did was we took animals with a double mutation at the apolipoprotein E site, which confers a rapid atherogenesis in the animals. This is used as a model for an awful lot of drug studies that look at the impact of anti-lipemics on atherogenesis and atheroma formation. We did a group with spinal cord injury. We kept a control group, and we had a group that was placed on disulcid. At SAC, we took out the aortas. They were fixed and stained with ORO, and then they were identified for the cross-sectional area of the tissues that were bound by atheroma. And these are the data. We're writing up the next paper on this. I noted before, salsylate improves glycemia. So it's not surprising there are pleiotropic effects here, but the anti-inflammatory effects, at 16 weeks, this is a representation of the ENFACE presentation, showing the aortic arch and the descending aorta through the thorax and down to the bifurcation. At 20 weeks, you can see the control animals without spinal cord injury start to develop disease, but those with spinal cord injury develop a lot more. Okay? And in the group that received the drug, we have much less disease, especially in the aortic arch, and even going down, you don't see a lot of disease here, okay, down before the bifurcation, where you do in the animals that don't receive the anti-inflammatory. At 24 weeks, this progresses to more disease, but still less in the anti-inflammatory treated animals. And at 28 weeks, you can see manifest disease much more in the spinal cord injured animals than in the non-disabled controls. And again, and with pretty substantial disease, going down, you can see it even invading, down with where the aorta splits, but actually far less here. And if we have this measured morphometrically by an investigator who was blinded to group assignment and the time of assessment, we find significant differences in the amount of lesion area. One of the things we're interested in doing is actually to repeat this study and look at what's inside the lesion, because we know that there are inflammatory cytokines that actually invade the atheromas and further promote lesion development. And this might be an important part of our consideration in the long-term management of the population. So we have to face some facts about some of the things that we've done with respect to lifestyle intervention. And these are perhaps some of the mea culpas. we know and have long known that people with spinal cord injury occupy the lowest segment of the fitness spectrum. There's almost nobody who is more deconditioned, even other populations with disabilities, than someone who has a spinal cord injury, and especially somebody who has tetraplegia, although the literature suggests when you do exercise testing on the two populations of tetraplegia and paraplegia, you would think that the paraplegics would be far more in better condition, but actually they're not. With respect to using physical activity, you can't outrun a poor diet. So if we don't correct nutrition, okay, and both in terms of total calories, which are probably about a third over what is needed for daily function in the population after their spinal cord injury, and we've published that, and Dr. Gator's published a number of papers, and we're certainly into SRs and other things that confirm this. If you're not eating properly, you can't exercise enough to outrun that. And conversely, nutrition as a monotherapy doesn't do everything we want in terms of the benefits of exercise conditioning. So, we also have to consider Mark Twain's admonition that lifestyle changes last about 2 weeks and are soluble in alcohol. And if I were there today, I would hope to get a laugh about that one, but it's startlingly unfunny because it happens to be true. So we began somewhere about 15, almost 20 years ago, looking at an optimal exercise prescription for this population. Juliana here is doing her circuit resistance exercise. She has a C5 injury, and she's swearing in Portuguese, which she does down on the first floor. We would want an exercise prescription to be safe. We would like it to benefit all of the attributes of fitness. There's always this emphasis on endurance because an endurance exercise test is a little bit easier to do than to actually measure strength or anaerobic power, okay? And almost very few people look at flexibility unless there's a pain issue, but we would want them to improve all of these because all of them are involved in ADLs. We'd like to get better musculoskeletal balance, the shoulder joint and the shoulder girdle, especially as patients propel a wheelchair, get stronger and more limited in range in the anterior chest wall and start to stretch out the rotator cuffs. We'd certainly like it to improve function. Function means different things to different people. My PT colleagues, think of function as task performance and ease of daily activities. I'm a physiologist. I tend to think of function as homeostasis. A lot of my physician colleagues think of function as illness and disease. So we have different perceptions about what is and isn't functional, and they're all accurate. Obviously, we'd like it to address risks and secondary complications, and we'd like it to be interesting and fun. Okay? Otherwise, people aren't going to do that. So because of this, it's important also to look at how these conditioning outcomes are delimited, and the head honcho for malapropisms, who was Yogi Berra, says if you don't know where you're going, you might end up someplace else, and that's true. So is the exercise we're doing or others are doing, I guess, successful at fitness in allowing people to acquire fitness? And the answer is yes. Okay, and I'll show you a little data, that will indicate that we can actually do pretty well in a relatively short period of time, in part because if you take someone who's incredibly deconditioned, you don't have to do an awful lot of physical activity in order to get them more conditioned. Fitness acquisition for all attributes of fitness, probably not. And again, one of the overlooked attributes is anaerobic power, which is important for people who are going to wheel a wheelchair up an ADA ramp or across the pavers that are in front of the Lois Pope Life Center, or maybe they have to cut across some stone or some grass because there are barriers to using smooth sidewalks and linoleum walkways. This is a really important and underestimated attribute of fitness that we've been successful in actually getting to improve. Dyslipidemia, we've shown improvements in dyslipidemia, but the exercise has to be sufficiently intense. And there's a good amount of the literature, even in spinal cord injury, that shows that low levels of conditioning or intensity targets that are low, may not significantly change dyslipidemia, whereas higher ones certainly do. Are we delimited in our understanding of all-cause prevention? Meaning hard outcomes. And the hard outcomes, again, are myocardial infarction, stroke, and sudden death. And the answer is who knows, because we haven't tested it. Okay? I don't know of a single study that has looked at hard endpoints, okay, as opposed to almost every other guideline in dyslipidemia and cardiovascular disease management that does. And this is obviously limited for the size of the population and how we gather these data in this population, given that a lot of the symptoms that one would normally associate, especially with MI and sudden death of cardiovascular origin, may be masked by the spinal cord injury and not identified. Dyslipidemia and insulin resistance, this is where I start thinking of the low-hanging fruit. There are an awful lot of articles that have looked at obesity management, which is certainly important and has implications on daily function if you have to transfer that mass and dress with that mass and do everything you do in an ADL with another 20 to 50 pounds of weight on you. It makes life harder, and certainly one of the key factors that causes shoulder pain that Dr. Widerstrom-Noga studies is body mass. So, but on the other hand, if the three risk factors that define a diagnosis for cardiometabolic disease are obesity, HDLs, and insulin resistance, if I wanted to deal with one quickly and get rid of it, this would be my choice. And this is one of the things that we're working on now, and focusing on how do we deal with insulin resistance? Because one of the messages for this morning is, of all the things that you can do with those 5 risks, this is the easiest to deal with. So does conditioning prevent functional decline, decline in ADLs? And Dr. Rachel Cowan always reminded us that the answer was not necessarily because the function isn't just a property of fitness, it's also skill. And if you take someone who's poorly skilled in their ADLs and you make them more endurant, stronger, and more powerful, okay, they can be as dysfunctional afterwards if they don't have skill. So again, it's something we think about. We started doing the circuit, that's on the first floor of the Lois Pope Life Center, and we hope soon to be moving to the Limb Rehabilitation Center. The idea was stolen lock, stock, and barrel from one of my PhD students, Pat Mosier, who did something like this for her dissertation in adolescent type 1 diabetics. And we found that it was actually more effective by not doing endurance activity, by integrating resistance activities. We actually found it was more effective for increasing endurance. This is after 10 weeks of exercise. I'm sorry, this is 4 months, pardon me. And it's the only one that just about increases anaerobic power, okay, which we started studying, and we validated the Wingate test for arm cranking in our laboratory somewhere about 2004. We had, we started this with individuals with paraplegia. We had a lot of complaints from the individuals who are tetraplegic that we weren't helping them. So with a grant from the Nielsen Foundation, we revised the circuit for individuals with cervical spinal cord injuries. We can go up to certainly C6, we can do C5, but it's a little bit more challenging. One of the things we did here was we played a physiology trick on the muscles. This was the circuit we published in 2014 for individuals with tetraplegia. There were 2 articles on this. What we found was that if we supplemented the nutrition for exercisers with 24 grams of whey protein, okay, both immediately before and within 1 hour of exercise, we found in those who had immediate protein supplement, okay, in that golden window, as we call it, that they had substantial improvements in peak oxygen consumption in levels of endurance. And this was also true of their strength. If they consumed that, then if we delayed that protein supplement for 24 hours but kept it isocaloric. So the control group got exactly the same protein, exactly the same dose, but 24 hours later where it's outside the window. And we found that individuals who received immediate lowered their total cholesterol to HDL-C ratio, which is a proxy for future risk of cardiovascular disease. They improved their insulin sensitivity using the HOMA model by 28%. This is one of the first studies that looked at improving insulin sensitivity. We did post-prandial studies on these individuals. They improved their triglyceride cycling by 52%, as assessed by area under curve. Glucose area under the curve was 83% lower, and it took significantly less insulin in order to lower this glucose, and that is the model for insulin sensitivity. And when we did just a standard 2-hour OGTT using a 75-gram glucose load, the 2-hour post-load glucose was lower by 27% after conditioning. So, and this was in, I believe, yeah, this was 6 months of conditioning. So in this period of time, we actually didn't find a significant change in body mass, okay, or a significant reduction in body fat mass. So one of the messages here is that we don't have to change body composition in order to improve insulin sensitivity. Okay, and that's, you know, kind of a mantra that we've started using, because the gold standard is always have people lost weight, and they can significantly improve their cardiometabolic risk without that improvement in essentially body mass or body fat mass. Now, we were funded after that by the Department of Defense as a CDMRP, and to look at essentially the diabetes prevention program, which was a 54-center NIH-funded trial that looked at the combination of exercise and Mediterranean nutrition, shown here, and there was a behavioral component. So there were 3 interventions clustered. And what was found, this was in individuals who had risk for cardiovascular disease but no disability. And what they found was that a 7% reduction in body mass on this profile reduced conversion to type 2 diabetes by about 58%, and was more effective than metformin monotherapy in doing so. Okay, and it became kind of the standard. It's still the standard. There are 3,000 centers across the United States that actually deliver this. It is durable. You know, the 10-year out studies and the 15-year out studies show that people maintain their resistance to diabetes. They still maintain lower body mass. And what we did for a DoD grant was to morph this into spinal cord injury, because we already had the exercise, you know, and the exercise in the DPP was 10,000 steps daily, excuse me. We just changed it to our circuit because obviously our subjects didn't take 10,000 steps. We took the Mediterranean diet, but we reduced the caloric intake by about 1/3 and created strata that we estimated would be needed in order to match daily need with daily intake. And we took the behavioral program and again morphed it into something that was appropriate for spinal cord injury. We published it in a number of studies that have described the program. You know, this is the first of the case series studies. We have more data on this still coming, but in the early subjects, there was a 6-month intense supervision of the program, which took place you know, at Lois Pope, and then we did a 12-month period of minimal supervision. just occasional contacts and checkups. We found that the body mass was reduced more than the 7% target that we were trying to achieve. Fasting glucose came down by almost 10%. There was an improvement in insulin sensitivity, and this is substantial and certainly higher in percentage in fasting glucose because it takes here less insulin to lower this amount of glucose. And that's a good thing, and again, that's representative of improved insulin sensitivity. In a non-disabled population, you expect a bump of about 10% for a 10-week exercise program. At 6 months, we saw about a 15% change. Triglycerides came down. This was above the level of risk at 150. We came down below it, and the important thing here was if we compared, excuse me, if we compared 6 months and 12 months, we found that the program was pretty durable, that an awful lot of the subjects maintained their benefits at 1 year out. So, and we continue on with this program. Now, not everyone can do this, okay? Not everyone has access to equipment that would allow them to do this. Certainly we published any number of barriers or identified barriers, be they financial, transportation, access to places where people with disabilities can work out. Somewhere around 2006, we published a TheraBand protocol that's being used by, I get a lot of calls about this, for people who don't have access to gyms, who don't want to go to a gym and work out with non-disabled individuals, who would want to shower afterwards but don't have access to showers or bathrooms. And so certainly we've had to look at other ways to deliver this. Right now, we are delivering it online. As we saw what was happening with COVID-19, and we were actually running out of disinfectant wipes, we designed an online program which we deliver Monday, Wednesday, Friday twice, and as of yesterday, the demand has been enough nationwide where we're going to Tuesday, Thursday sessions once a day. That actually will be initiated today. So this has actually forced us to look at different ways for us to deliver these services, and it's something that we'd like to continue when we go into the Lynn Center as a community outreach. We've engaged peer support groups in Miami-Dade, in Broward County. We've engaged Sabrina Cohn and her foundation. So we have an awful lot of people joining us. We have a Paralympian from Tennessee who joins us 3 days a week. We're looking at this as perhaps a new way in which we deliver these services while removing some of the barriers that we've had with people, having to come perhaps to the Lois Pope Life Center to use the specialized equipment that we have. But if we don't want to, or we can't undertake physical activity because of very high levels of injury or these barriers, is there nothing we can do? And, we started looking a couple of years ago at not undertaking physical activity or nutritional modification at all. Okay? And this came about from interest in essentially modifying molecular expression of myogenesis by a number of techniques. Dr. Bigford, along with John Bethea when he was here, Valerie Richard and I published a paper, again, Dr. Bigford, first author, that looked at uracilic acid, okay, as an anabolic, approach toward modifying the mTOR signaling pathway. And in experimental animals, it was successful in improving lower extremity or sublesional muscle mass, even though the animals were not on a physical activity program. So that also caused us to look at other ways in which we might affect myostatin signaling. And by happenstance, I was invited to a limited meeting up in Cambridge from a company called Scholar Rock. Scholar Rock is a company founded by Tim Springer at Harvard. who's published about 600 papers on inhibition of myostatin signaling, which are somewhat modeled after what you see in the upper right, which is a Belgian blue bull. Now, this is a naturally occurring mutation. It's a double mutation of the myostatin gene. Myostatin is in the GDF8 superfamily. It's a myokine that inhibits myogenesis, and yes, it is elevated in spinal cord injury. So the Belgian blue, again, homozygous recessive for this mutant allele, has exceptional muscle mass. What you don't see, or perhaps it is visible, is it's exceptionally lean mass. Okay, and that's important for us in spinal cord injury, in large part because there's so much fatty infiltration in skeletal muscle. And that's one of the reasons that the BMIs, for every BMI unit of an individual with spinal cord injury, they actually have more body fat than an individual without a spinal cord injury. So there are other naturally occurring mutations of the myostatin gene. This is the myostatin whippet. This is a myostatin trout. Yes, you can inject myostatin inhibitors. There are different ways to do it. Some of them are more successful than others. And this is what happens to a rat when you give it an intraperitoneal injection of a myostatin inhibitor. In the case of Scholar Rock, the myostatin antibody product that they developed is selective for the GDF8 superfamily. They're the only people who've done this. And we've linked with them to do preclinical studies in spinal cord injury and see if we can replicate this, and also to see if we can't translate this for human use. Our goal is about 1.5 to 2 years from now. Now, these are data from our pilot study, and again, Greg gets props, because he's doing the heavy lifting on all this. We looked at, these are animals, C57BL6, some of which have spinal cord injury. Here's a sham group. Here's spinal cord injury with a control, IgG. And we have spinal cord injury with the test product, which is SRK-015 or SR-015. Both terms are used. We've shown target engagement of the antibody in gastrocnemius, triceps, and serum. And at SAC, if we look at sublesional soleus and gastrocnemius, looking at the bar graphs first, we find that there's significantly more gastrocnemius mass even than the non-disabled control group, okay, but certainly different from the spinal cord injury group, and the same is true of soleus. And these are representative views of the soleus muscle at SAC. Here's sham. Here's a very atrophied soleus with the SCI with just the vehicle that we use for SR-015, the control with IgG, and this is the drug-treated animal. So body mass over a 2-week period post-injury is maintained in the antibody-treated animals, obviously different from the animals that don't receive the selective inhibitor of myostatin. If we look at lean mass, again, it's different from the IgG-treated animals, and actually not different from the sham. And if we look at total energy expenditure, we're fortunate. Dr. Ernesto Bernal Mizrahi is the chief of the division of endocrinology, and next door to us in Bachelor, he allows us to share his metabolic chambers. We've been doing metabolic studies to see if energy consumption and thermic effects are higher in the treated animals than in the untreated animals. And our first look at the pilot data said they were. Okay, one of the things that I found especially intriguing was we've talked about the infiltration of muscle with fat, and we did histology to look at intramuscular lipid stains, and we find actually that animals treated with the test product have less intramuscular lipid And I don't think you have to look at the bar graph to see what the sham muscle looks like in cross-sectional, for cross-sectional diameter versus the untreated muscle versus the antibody-treated muscle. So in the pilot, we did what we thought was good for earning further study. We received an award from the Department of Defense. It's not a clinical award, it's not an investigator-initiated, but actually it's specifically for translation. And we made a case for how, if our data supported, we would move to human studies in spinal cord injury, probably within 2 to 3 years. And that was 2 years ago, maybe a year and a half ago, when the award came. Again, these are data generated in large part by Greg Bigford. The latest, oops, sorry. Early on, 2 weeks post-injury, we find significant benefits for the drug in preservation of soleus mass and gastroc mass. These are actually the serial changes in metabolism over about a 48-hour period. You can see the diurnal variation that takes place, and in blue above is the energy consumption or the oxygen consumption in milliliters per kilogram per hour of the drug-treated versus the vehicle-treated animals. Not only is there more oxygen consumed, more energy metabolized, but there's also a shift in fuel partitioning, favoring higher levels of carbohydrate consumption here. There's a higher thermic effect, okay, of the drug on heat generation in kilocalories per hour. And if we measure or we average oxygen consumption in mils per kilogram per hour, we find that at 2 weeks, it's significantly higher in the drug-treated animals than in the animals treated just with vehicle, and these are also spinal cord injury. So our goal, and this is a work in progress still, is the design actually compares early and late administration of the antibody to see if this is something we have to do immediately after injury, or is this something we can do, for example, with a chronic injury years down the road, okay, and decrease intermuscular fat and increase oxygen consumption. And we also have a group that has normal chow versus a high-fat diet to see if we can make a fat mouse. Does this help them more or less or the same as a mouse that has a non-fat body habitus? Now, the goal, just to give you a look ahead, SRO15 is currently in phase 2 clinical trials. It's received an IND and has been fast-tracked by the FDA to look at the first population, which is spinal muscle atrophy. This was the plan of Scholar Rock to do SMA first, to do spinal cord injury second. There are actually 2 labs in the country, ours and Bill Bauman's, that have the product. Each of us is going in a little different course, but we're both tracking toward a clinical trial. So what our plan is presented was to piggyback an IND on what thus far has been success in treating SMA in type 2 or type 3. If you're not familiar with SMA, it's a genetic disorder that results in severe atrophy of the diaphragm muscle, and most of the children and young adults die of respiratory failure because of it. The data on this are still embargoed, so we don't know exactly what's happening in them, but right now, certainly the DSMB has not stopped the trial, and they're about 2 years into, I believe it's 12 centers nationally, the lead centers at Stanford. So it's our plan, okay, if our data continue to trend this way, and we can unembargo these data so that we write the next grant, which would be first in human studies, to consider doing the same thing in individuals with spinal cord injury. Now, briefly, This isn't our only approach in managing obesity and insulin resistance, and I won't spend long on it. I brought back Dr. Monica Perez, who published a number of works and continues her work on intermittent hypoxia and its effect on neuroplasticity, corticospinal synaptic plasticity. One of the, I guess, less known secrets in spinal cord injury is that intermittent hypoxia by a different protocol that's used by Monica and Randy Trunbauer and Zev Reimer is actually being used to lower, to lower blood glucose. It's been shown in both human studies and in preclinical studies to benefit insulin resistance and dysglycemia. We know certainly time spent at a high altitude results in a lower body fat and enhanced glycemic control. It takes very few sessions, and if we're talking about low-hanging fruit, of intermittent hypoxia to improve insulin sensitivity. And we've started testing this. We reported the first of the data this year at the ACSM meeting in 4 subjects, and when compared to baseline, over a 2-week period, persons with spinal cord injury had a lowering of blood glucose, the area under curve in an oral glucose tolerance test, and a decrease in the amounts of insulin that was necessary to lower it, and that was actually after 4 days of intermittent hypoxia. And part of this week has been rewriting a letter of intent to the Nielsen Foundation to fund a 2-center trial on this. We've cleaned up the protocol from first attempts. There have been changes in the literature that suggest a little bit more effective, and that's our next pursuit with respect to intermittent hypoxia. So to conclude, we've come to the fork in the road. It's time we do something about it. We've been talking about it, the problem, for 20 years. We know that sarcopenic obesity or neurogenic obesity, abnormal glucose metabolism with dyslipidemia are more impactful on spinal cord injury than the non-disabled population. One of the things that I guess is underestimated is the impact of this on activity, life satisfaction, productivity, and health. So it's not just a glycemia issue, it's not just a lipid disorder issue. Ultimately, this can have an impact on the independence of our patients, which is obviously prized after spinal cord injury, and we still have to consider their caretakers. And if you're not aware, caretakers are falling apart. Okay? And by age 60, there was an article that reported that the caretakers of people with disability spend more time in the emergency room than the people they care for. The other thing is just a practical issue, and we talked a lot about this with Dr. Gant, is the eligibility of our subjects for participation in trials using technologies like ambulation exoskeletons. Usually depends on them being in pretty good shape. Okay? And if they're not, most of the exoskeletons have an upper limit of body mass of 220 to 240 pounds. And if you're above that, you can't use it because they can't support you and the risk is too great. So, we want to make people as eligible as possible. There isn't one-stop shopping. Again, we have new ways of modifying gene expression. Intermittent hypoxia may serve a role. We're appreciative for Neidler and DOD, Craig Nielsen Foundation. We have 3 awards from them presently through various investigators. The PVA has now funded Dr. Gant and I to write the first consumer guideline on cardiometabolic disease management. We're blessed with great colleagues. I didn't mention the surgical and microscopy cores, but we're very grateful for the work they do and the oversight of them. Scholar Rock, the Model Systems, these are the centers that are collaborating with us on some of the work, and the PVA and Cheryl Vines, their research director. So thank you very much.
Great job, Mark. Great overview.
Thank you, Dr. Green. Let me see if I can get pictures back up.
Mark, this is
Yes.
Dalton.
Morning, Dalton.
Thank you very much. One of the areas that people are looking at more and more is cognitive decline in the aging spinal cord injury population. I was wondering, as you're looking at cardioendocrine changes and effects on different types of quality of life, could that also be studied in reference to long-term cognitive problems some patients may have, some subjects may have, or is that a stretch?
Yeah, and it's a good question. It's in a really important area. There have been early studies showing association of higher levels of body fat with premature cognitive decline in the spinal cord injured population. We've started reaching out to our institutional resources to see how we would study this. And again, we suspect that there's an awful lot more opportunities for us to study a lot of things early intervention, okay, where for many years we haven't had the opportunity to do that, and the new center makes that not just a possibility, it's an eventuality, where we start intervening immediately, and that's certainly one of the areas in our thought processing, especially because it's, again, so pro-inflammatory, and it's associated with atherogenesis. So yeah, it's certainly important.
I remain pretty excited about the Scholar Rock program, and I'm glad you talked about it a little bit. I hope the audience appreciates the importance of those studies and how important they would be to translate to the clinical arena, and hopefully we can again communicate with the company to try to make that process go. I just thought of another experiment. I just sent you and Greg another experiment. Maybe we can use some of the tissues we have in terms of some of the inflammasome signaling cascades in muscle tissue during atrophy, but we can talk about that later. But
yeah, I somewhat ironically, we had the first meeting of an advisory board that they selected, and I was in Cambridge, and after the meeting they asked me to stay, okay, and talk, and the first question was, are you allowed to work with Helen Bramlett? And I said, why wouldn't I be allowed to work with Helen Bramlett? And they said, oh, okay, we just wanted to know because we're interested in animal models. We hadn't discussed animals at all in that meeting. It was all human research. But they knew we were doing contusion lesions, okay, and that we were very skilled in it from all the work that's being done on floors 3 through 6. And some of the other centers were using knife cut, and that's one of the things that got us the product. Okay, was our willingness to cross boundaries in our levels of disciplines, and they knew that people of various disciplines interacted within the project, whereas oftentimes they don't, and that actually turned out to be one of the reasons that we're one of the 2 centers worldwide that has this product, which is, I agree, Dalton, very exciting.